Good evening, and thank you for joining us tonight. My name is Dr. Maribel Hernandez. I'm a cardiologist at Lancano Heart Institute, and I am the medical director of the Women's Heart Initiative. The Women's Heart Initiative was developed to encourage women to learn the truth about heart disease and the risks it poses to us, and also to use that knowledge to make informed decisions about healthcare and get the best and equal treatment to live healthier lives. We're here tonight to discuss a very important topic, diabetes and heart disease. Despite major advances in cardiovascular research and treatment over the past decade, women with diabetes are at higher risk for cardiovascular events. In fact, women with diabetes have twice as likely as men to develop heart disease. This evening, I have the privilege and the pleasure to introduce two mainline health physicians. Dr. Divyan Tovani is the Assistant Chief for the Division of Endocrinology at Mainline Health System, and Dr. Mara Caroline, Interventional Cardiologist for the Lancano Heart Institute. She also is board certified in lipidology and integrative medicine. At the end of the presentations, we will be taking questions through the chat box. So feel free to use the chat box during the presentations. So let's get started. Dr. Tovani, thank you for joining us.
Thank you, Dr. Hernandez. And I am delighted to be here. Thank you to all of the participants in this webinar this evening. I was asked to speak about the diagnosis and treatment of diabetes. We will primarily speak about type 2 diabetes because of the advances of medications for that type of diabetes. So let's get started with the first slide. So what is diabetes? Patients that have diabetes have either an insufficiency in the production of insulin from their pancreas, or if their pancreas is producing insulin, the cells of the body are not properly using insulin. So insulin is a hormone that is secreted from our pancreas that is needed to convert sugar and starches and other food into energy that we need to do daily life activities. In the absence of insulin, the peripheral cells of the body, the fat cells, the muscle cells, the liver cells, cannot take up glucose in order for the glucose to be utilized as energy. And this results in the body experiencing high blood sugar levels. If left untreated, high blood sugar or diabetes can cause long-term complications like blindness and kidney insufficiency, kidney failure, foot and leg problems, amputations, and even cardiac complications. Next slide. In general, there's two main types of diabetes. Type 1 diabetes is defined by the pancreas making either no insulin at all or very little insulin. And remember, the pancreas is that organ that sits behind the stomach and secretes insulin in response to food. Type 2 diabetes is defined by two mechanisms. One, over time, an inability to make insulin in order to metabolize carbohydrates and starches. And also, type 2 diabetes is defined by what we call insulin resistance. So patients that have type 2 diabetes have a deficiency of insulin being produced from the pancreas, but also the insulin that is produced from their pancreases is in fact not able to bind to cells and do what it's normally supposed to do. And that's called insulin resistance. I want to speak about one other form of diabetes on the next slide, which is gestational diabetes. For younger members of our audience this evening, I want to define what gestational diabetes is. It's really the development of high blood sugars during pregnancy. And unfortunately, there is an increase in the incidence of gestational diabetes in our younger women who are overweight and who are obese. Gestational diabetes is important, not only because it can cause maternal and fetal consequences, but also because it's a strong marker for the eventual development of type 2 diabetes in the future. I want to just share with you a patient that I saw just last week. She was in her early 50s and she was referred to me for newly recognized uncontrolled diabetes. And when I took her history, she told me that she had gestational diabetes when she was pregnant, twice in her younger years. And she had a strong family history of diabetes. She had gestational diabetes, and lo and behold, in her 50s now, she's developed herself type 2 diabetes. The maternal and fetal consequences of gestational diabetes can be, for the mom, high blood pressure at the time of pregnancy, preeclampsia, protein excretion in the urine. And for the fetus, in the presence of gestational diabetes, if left uncontrolled, babies can be born large for gestational age. And the members of the audience know what that could mean for delivery. That could mean certainly complicated deliveries. But gestational diabetes can be treated. And so providers tell their women patients who have gestational diabetes, they refer them to our diabetes educators, to our nutritionists across Mainline Health, and they are in fact sometimes required to use medications. And most of us would use insulin in women who have gestational diabetes for the time during their pregnancy. Next slide. I want to define what one of these major forms of diabetes is, which is type 1 diabetes. As I said, the pancreas is the only organ that makes insulin, and the beta pancreatic cells are the cells that secrete insulin from the pancreas. The classical signs of high blood sugars, type 1 diabetes, can be increased thirst, increased urination, blurred vision, weight loss. Usually, these symptoms come on very abruptly in type 1 diabetes. Type 1 diabetes is usually defined by complete insulin deficiency, and these patients have an absolute dependence on insulin. They must be treated with insulin. Patients that have type 1 diabetes are prone to an altered state of high blood sugars called diabetic ketoacidosis. So you may know family members, young nephews or nieces that may have gotten admitted to the hospital with diabetic ketoacidosis. And in general, patients that have type 1 diabetes usually have the onset of this disease before the age of 40. And these patients are defined not by being overweight, not by being obese. In fact, these patients tend to be more lean in their body habitus. So in general, this is what defines type 1 diabetes, as opposed to the next slide, which defines type 2 diabetes. Type 2 diabetes can be insulin deficiency coupled with insulin resistance. These patients are not absolutely dependent upon insulin. However, with time, we know that patients that have type 2 diabetes may develop into requiring insulin, but they're not absolutely dependent upon insulin. The symptoms of type 2 diabetes are of progressive, gradual onset. So patients do have increased thirst and increased urination and blurred vision and weight loss, but they may attribute these symptoms to other things. For instance, I once saw a patient that said to me, well, I did have increased urination, but I was pregnant 4 times and I delivered 4 babies vaginally. So I thought that my increased urination was because of a dropped bladder. I interviewed a gentleman one time, and he said to me, yes, I knew that I had increased thirst, but I was working in the garden all summer. I was doing things around the house. It was a very hot summer. So I thought my increased thirst was due to the activity that I was doing at that time of the year. So the classical symptoms are still there, but sometimes patients may find other reasons why they have these symptoms and not attribute it to high blood sugar levels. Type 2 diabetes has a very strong family history associated with it. Type 2 diabetes is usually diagnosed after the age of 40, usually. However, we are seeing an epidemic in younger children who are overweight. So years ago, when we saw an adolescent that developed diabetes, we would start them on insulin and define them as having type 1 diabetes. But in fact, with the epidemic of overweightness in young adults, young children, these patients actually have type 2 diabetes. Type 2 diabetes also has a higher incidence in certain ethnic populations like Native Indians, Asian Americans, and African Americans. So we are very keen on getting patients who are in these certain ethnic groups certainly screened for diabetes. Next slide. So what are the numbers? What defines diabetes? So let's start on the right-hand side of the slide. So diabetes is defined by a fasting blood sugar greater than or equal to 126 on 2 separate occasions. And also, diabetes can be defined by an A1C greater than or equal to 6.5. So for example, if your provider sent you for blood work and the blood work shows that your cholesterol is good and your liver tests are good and your kidney functions are fine, but the provider tells you that your blood sugar is 139. So what you want to do is be sure that you're having that blood sugar checked again, because you want to know whether you have the criteria for the diagnosis of diabetes. You want to get that fasting blood sugar checked again. And of course, if you do, then you want to begin treatment. Let's go to the left-hand side of that slide, pre-diabetes. So pre-diabetes is defined by a blood sugar fasting, anywhere from 99 to 125, with a hemoglobin A1C between 5.7 and 6.4. And so pre-diabetes is important because there are millions and millions of Americans, and I'll show you this on another slide, that actually have pre-diabetes. If left untreated, pre-diabetes then forms into frank type 2 diabetes. Next slide. So this is a cartoon that I pulled out of some of my slides, and I just wanted to show you how the body regulates blood glucose by removing excess glucose after a meal. So if you start on the top left-hand part of this slide, this is a blood vessel, say an aorta, the major blood vessel in our body, or a blood vessel that's supplying our kidneys, or a blood vessel that's supplying our heart. After a meal is ingested, a meal of carbohydrates or a meal of starches, these are metabolized into glucose and absorbed into the blood, absorbed and enter the blood vessel. With that, the pancreas, on the right-hand side of the slide, the pancreas produces a hormone called insulin, which helps the body absorb the glucose. So the peripheral cells, like muscle cells and fat cells and liver cells, in the presence of insulin, will pick up that glucose out of the blood vessel and bring it into the cell where the glucose is utilized as energy. So that allows us to walk to the train station. That allows us to work in the garden. That allows us to write a book report. That allows us to do tours around the house. So when you take glucose and you bring it into the cell to be utilized as energy, then you lessen the amount of glucose that is in that blood vessel. And that's what basically the normal metabolism of glucose is. In contrast to the next slide, which shows patients that have diabetes or type 2 diabetes. So here's that same blood vessel with the ingested carbohydrates that are converted to glucose. The pancreas in type 2 diabetes, remember, has a two-pronged deficiency. There is either a deficiency in insulin secretion, or the insulin that's made by the pancreas does not bind to the cells in a normal way. There is a resistance to binding the insulin at the cellular level. So that glucose does not get taken up by the cells. And therefore, with that, you have high blood glucose remaining in the blood vessels. And so that, in essence, is what defines type 2 diabetes and the defects that type 2 diabetes portends onto the body. Next slide. Next slide. Hyperglycemia or high blood sugars or diabetes can cause long-term serious complications. So we'll stay on the left-hand side of the screen right now. We'll talk about microvascular complications like retinal problems, which can cause blindness, or kidney problems, which can cause kidney insufficiency and can evolve into kidney disease, which may require kidney dialysis, and nerve damage, which is commonly known as neuropathy, and then amputation of lower extremities, appendages, things like that, because of small blood vessel damage in the smaller arteries. And then on the right-hand side of the slide, and if you can advance to the next slide, please, we talk about the maculovascular complications. We talk about strokes and heart attacks and poor circulation involving the larger vessels. So if you look at that healthy artery on the left, if you take an artery like the aorta or the coronary arteries or the femoral arteries that are in our legs, and you take a cross section of that, you see that it has a very nice lining. The endothelial lining is very nice, and the flow of blood through that artery is not impinged in any way. But with the development of fatty deposits, atherosclerosis, hyperlipidemia, uncontrolled diabetes, then that artery occludes and you cannot get blood through that artery, and you cannot supply blood to the organ that that artery is trying to supply. So that could end up in a stroke if it's the carotid arteries, or a heart attack if it's the coronary arteries, or lower extremity insufficient blood supply causing gangrene and loss of limb in the lower extremities. So the risk of keeping blood sugars high can lead to some of these complications. Next slide. I just wanted to touch about diabetes and stroke, diabetes and cerebrovascular disease. It's interesting to note that frequency of diabetes in stroke patients is 3 times that of non-diabetic patients. And in fact, worsening diabetes control relates directly to stroke risk. So the more you have uncontrolled diabetes, the more risk you have of having a cerebrovascular accident or a stroke. And there was one paper that I read, in fact, that patients who are younger than 55 who have diabetes have an increase in stroke of greater than 10-fold that of non-diabetics. And so stroke and diabetes certainly increases mortality. So I just wanted to touch upon that. Next slide. The prevalence of diabetes in the United States is quite impressive. of the 31 million Americans in the United States, and this is data from about 2019, 10% of the United States population has diabetes, 10%. 84 million Americans have prediabetes, and that's why I wanted to define what that was. And of those with diabetes, 7 million are undiagnosed. So 7 million folks in the United States are walking around not knowing they actually have diabetes or prediabetes. And it is the 7th leading cause of death. And those among us this evening who are a little bit more mature will recognize Mary Tyler Moore, who has type 1 diabetes, who had type 1 diabetes, and Jack Benny, who had type 2 diabetes, and Ben Vereen, who was here at Lankenau several years ago, and he told us about his journey with type 2 diabetes. And the younger members of our audience tonight will recognize Halle Berry and Nick Jonas, and they have type 1 diabetes. And even one of the Supreme Court justices, Sotomayor, has type 2 diabetes. And she's very, very vocal about her disease. And it's important for her ethnic population because among those folks of Puerto Rican and Spanish descent, they have a higher incidence of type 2 diabetes. Next slide. So what are the targets? What should the targets be for your glucose and your A1C? So in general, patients that have diabetes, their before meal blood sugar should be no more than 130 milligrams per deciliter. And their 2-hour after meal blood sugar should be no greater than 180 milligrams per deciliter. And their A1C in general should be less than 7. Now, I would tell you, depending on your state of disability, depending on your concomitant illnesses, your provider may alter these goal levels for you. But in general, that's where we would want them to be. Next slide. And so the treatment for type 2 diabetes may change over a lifetime. So when first diagnosed, depending on the level of A1C and depending on the level of your blood sugar, your provider may tell you, let's get educated. Let's see a nutritionist. Let's see a diabetes educator. Let's start checking your blood sugars. Let's begin an easy exercise program. So all of that may start concomitantly, maybe with oral medications. But with time, next slide, that may change on into other medications, some oral and some injectable medicines like insulins. And so you will recognize some of these medications, and please forgive me for using the trade names here. I just pointed these out because I know there are a lot of direct-to-consumer advertising on television. So you may see commercials about these medications. And I want to tell you some of these newer medications not only treat type 2 diabetes, but in fact have a cardiovascular benefit for patients that have hospitalizations for heart failure, for patients who have diagnosed heart failure, for patients that have kidney insufficiency. You'll see some of the older medications that I have listed here. These medications are very inexpensive, but they tend to cause a lot of hypoglycemia. So you have to be very careful when you're taking them. And then metformin at the top is usually one of the medications that's started first early on, and metformin can also be used for prediabetes. We have some of the insulins. We have basal insulin, we have rapid acting insulin, and intermediate acting insulin. And on the next slide, I want to show you other medications that can be used for type 2 diabetes. And again, I'm using the trade names so you know these medications. You see advertisements for these medications. These are injectable medications, but these are not insulin. These are hormones that have been found to be either deficient in patients that have type 2 diabetes, or there's a resistance to these hormones in patients that have type 2 diabetes. These medications allow the pancreas to make insulin when food is around. So they do not cause hypoglycemia in and of themselves. They only allow the pancreas to make insulin when food is around, and that's what you want. These medications can also allow patients to lose a couple of pounds because they delay gastric emptying. They delay the food transit time out of the stomach into the gut. So what does that do? It makes a patient feel a little fuller, so you may not go for a second helping or a third helping of food. So the treatment for type 2 diabetes may change over a lifetime. And we are so fortunate now to have medications such as these to treat patients that have type 2 diabetes. And in fact, many of these medications can be used concomitantly with some of the medications that I showed you on the previous slide. So in general, in summary, on the next slide, again, treatment for type 2 diabetes may change, but in summary, type 2 diabetes is a progressive but manageable disease. Type 2 diabetes evolves from two primary defects, insulin deficiency and insulin resistance. Uncontrolled hyperglycemia can lead to serious complications, but we are very, very fortunate that the medications that we have available to us today can in fact treat type 2 diabetes, can help patients that have cardiovascular compromise, and the risks of the complications of uncontrolled diabetes can be reduced by tight glucose control. So thank you so much for your attention. And I'd like to introduce my colleague, Dr. Mara Caroline, who's going to speak about the cardiovascular complications specific to women and heart disease. Thank you, Mara.
All right. Hello, everybody. It's a pleasure to be here. Today, I'm going to follow Dr. Tavani and take us from diabetes to the connection between diabetes and heart disease in women. So just a little bit here about heart disease and diabetes. So among both men and women, diabetes is definitely one of the strongest cardiovascular risk factors.
Dr. Caroline, excuse me one second. Do you want to share your screen?
Oh, I thought I was. I'm sorry. Oh, I didn't click. Sorry about that.
There you go. Thank you.
Okay, I'm sorry about that. Okay. So diabetics, people with diabetes are more than twice as likely to develop coronary artery disease, heart failure, and peripheral artery disease, all of which are basically different forms of the same thing. And in this country, as well as all over the world, the prevalence of type 2 diabetes is going up. Therefore, the overall rates of heart disease in diabetics is going up as well. And as we know, heart disease in women is, even in non-diabetic women, is understudied, under-recognized, underdiagnosed, and undertreated, and especially so in patients with diabetes. And in addition, diabetes is often less appreciated as a significant risk factor in women than it is in men. There are gender differences as well. Women with diabetes, sorry, give me 1 second. Women, as compared to men with diabetes, are at higher risk of cardiovascular disease. So, you know, if you have a man and a woman who both have diabetes, what I'm saying is that women may be more at risk, even though this is not something that's really generally recognized. Men with diabetes have 2.5 times the risk of ischemic heart disease compared to men without diabetes, while diabetic women have a 3.5-fold risk compared to women without. In the Framingham study, which followed women for a long time, men and women for a long time, almost 40 years, diabetic women were noted to have a greater age-adjusted risk of peripheral artery disease, which is basically the same process that causes disease in the coronary arteries, but affects the legs with a risk ratio of 6 versus 2.9 in men. Also increased risk of heart failure and overall cardiovascular events. So that includes heart attack and stroke with an age-adjusted risk of 3.7 versus 2.2 when compared to men. And additionally, this is really important in women, the mortality is higher. So that means that the risk of death due to heart disease in diabetic females is 50% higher when compared to men with type 2 diabetes. So why is there this gender difference when it comes to mortality of heart disease in women with diabetes? Why do women with diabetes tend to do more poorly and have worse heart disease compared to men with diabetes? So this is, there's no one answer here. There's probably multiple reasons, some of which I listed. For one, it may be that women with diabetes have more adverse cardiovascular risk profiles. There could be also an anatomic difference. Dr. Tavani had that cartoon of an artery filling up with plaque, and women have smaller arteries. I don't know. That could be. Certainly, heart disease it is harder to diagnose in women. This may be because of the lower prevalence of obstructive disease, but greater burden of symptoms. And often these symptoms might be atypical. They may not present the same way as they do in a man, which may be less of the textbook chest pain and, maybe reflux, maybe shortness of breath, maybe totally different presentation that catches us off guard. Also, traditional testing is less sensitive and specific in female patients, and especially so in diabetics. And this may at least be in part related to the underrepresentation of women in clinical trials. There is also definitely a sexual disparity in the management and treatment of cardiovascular risk factors in women with diabetes. So we are less likely to treat women compared to men who have the same risk factors, less likely to optimize their cholesterol and their blood pressure, and put them on aspirin. And very importantly, there's a lack of recognition of diabetes as a significant risk factor in young females. So generally, you see a young female, you consider them to be at low risk. But what people do not realize is diabetes is associated with presentation at younger ages. It kind of changes the whole paradigm. And what you expect when you see a young woman, may not be the reality if she has diabetes. So then there's the question of how does diabetes contribute to heart disease? And there's probably multiple pathways here. I'm just going to hit on the two big ones, which are the impact of inflammation and also the effect on the lipoprotein particles, which are the particles that carry cholesterol and triglycerides around the body. So for one, inflammation and increased oxidative stress. Heart disease, I'm calling it atherosclerosis here, is a chronic inflammatory disorder of the arterial wall. It is first and foremost an inflammatory disorder. And when you have diabetes, elevated glucose levels, as well as multiple other pathways are activated, which are pro-inflammatory and kind of help to start the fire and fuel the fire, so to speak, and facilitates the progression of heart disease. In terms of its effect on the cholesterol numbers, there are changes for sure in the blood lipid profiles in diabetics. may shift the particles to become more atherogenic, which just means they're more likely to get into the wall of the artery and cause disease in the wall of the artery. You may have heard of small LDL particles, triglyceride-rich lipoproteins. Diabetes shifts your lipoproteins in this direction. Additionally, you can get modification of the LDL via glycation, which just means sugar sticking to it, which alters the physical and chemical characteristics of the particles, and that also causes more inflammation and activates pathways that facilitate the entry of these lipoprotein particles into the wall of the artery, which is the crux of the problem. So both of these contribute to accelerated development of heart disease. This is just a cartoon which is portraying what I was just talking about. So here you have diabetes at the top, and then down here at the bottom, you have right here where my pointer is, this is the lining, the thin lining of the blood vessel. And then back here, this is the wall of the blood vessel. And that's where the disease is happening. That's where the plaque is building up here in this lipid core, and it's starting to protrude into the lumen of the artery. And so what gets us from diabetes to forming this lipid-rich plaque in the wall of the artery? We have dyslipidemia, which is atherogenic modification of the lipoprotein particles and shifting them into the direction of smaller particles and triglyceride-rich particles. And then they are able to get across the endothelial lining and start causing issues. We also have the hyperglycemia and the insulin resistance, which trigger oxidative stress and all these signaling pathways that are highly inflammatory, and of course make this endothelium more dysfunctional, more permeable to the lipoprotein particle, which then is able to get in and start causing problems. So it's not really clear what the mechanisms are by which there is by which gender differences modify the prevalence and incidence of heart disease in the context of diabetes. So, why is diabetes in women potentially having a more atherogenic effect, more likely to cause heart disease than diabetes in men? It's not clear. Many proposed mechanisms are linked to sex hormones, which may influence the regulation of the immune system in both sexes. There may be biological, behavioral, or social mechanisms involved in this discrepancy. But the bottom line is, and hopefully you can see this, there does seem to be an impact here. So this table over here, hopefully you can see this. So this column over here is sex differences, premenopausal women versus men. And then here we add in the effect of diabetes. And it's clear that, so when you look at cardiovascular risk and fatal coronary artery disease risk, when you look at premenopausal women versus men without diabetes, less likely. When you look at those in diabetic women versus men, more likely. Then there's different factors here that are linked to sex hormones and immune regulation and lipid metabolism, where you definitely see there's a difference. So the relationship between the difference between men and women changes when you add in the impact of diabetes. And so, there's a lot to learn here. This is just kind of, ideas that are scratching the surface, but it's certainly an important area to keep understanding more about. So prediabetes is important too. So, you may see your doctor and they'll say, well, your hemoglobin A1C at 6.4, you're not diabetic yet, you're okay. But it is important to recognize diabetes as a continuum of disease. And, the further the ball rolls downhill, the more damage it's going to cause, and the harder it is to kind of move in the other direction. And it does seem possible that prediabetes may be more detrimental in women than in men. Unclear exactly why, but the phase of prediabetes can be long. It can be decades, and especially if ultimately when you cross over to officially being labeled as a diabetic, that delay, there's a delay there, and you can have significant metabolic and vascular injury during that time. So that is really important to not just think about whether you're diabetic or not diabetic, but where you are on that spectrum. And the things that can push you towards diabetes, obesity, inactivity, diet, aging is just naturally pushes you in that direction. Whereas forces that can kind of keep you healthier and away from prediabetes or diabetes are keeping a lean weight, keeping active, and making sure to pay attention to your diet, stay away from sugar processed foods. So knowledge is really power here. I would say that the most important thing is you first and foremost have to know what your risk factor is for heart disease and your risk for diabetes. So some of this comes from your family history. Some of this comes from just knowing your own labs and imaging tests, a coronary calcium score, which can screen you for heart disease, a cholesterol panel, as well as some specific genetic components that are easy to check that can help you know if you're at higher risk, blood pressure, your BMI and your waist circumference, your hemoglobin A1C, your fasting blood sugar, your insulin levels. Most important is just really following a healthy, heart healthy, diabetes healthy diet and lifestyle. And the most important interventions here, so identify and treat your risk factors for heart disease. Make it your goal to prevent yourself from getting diabetes. I would say that it's pretty rare to see patients who are, and maybe Dr. Tavani can comment on this afterwards, patients past their 7th or 8th decade who don't have a hemoglobin A1C at least in the pre-diabetes range, even if they're lean and healthy in other ways. So, always look for early signs on your labs, eat right and exercise regularly. Definitely higher levels of activity are associated with lower risks of developing diabetes. I'll put in a plug for managing chronic stress, which increases your cholesterol as well as increases your risk of developing diabetes. I think that's something that's really under recognized and under treated. And really important is advocate for yourself. As I have said, women with diabetes tend to be undertreated. They are not really recognized as having a significant risk factor. And so they're not optimized with the appropriate intervention. So know your risk and seek treatment. And thank you for listening. I'm going to try to stop sharing my screen here.
Thank you, Dr. Tavani and Dr. Caroline, and for the excellent presentations. And I guess you'll go ahead and answer some of the questions.
Yeah, so there's a couple of questions in the chat box, which are really great questions. The first question is, as I age, how can I continue to keep my A1C at a healthy level without medications? So as we stressed in this lecture, without medications, do whatever you can with behavior modification, increasing your exercise habits, keeping lean, choosing the right types of foods, staying away from processed foods, processed sugars, things like that. Without medications, that's how you can do it. With time, as we age, our pancreas naturally produces less and less insulin. So it's not uncommon, as Dr. Caroline alluded to, that we would see patients who are a little bit more mature, who don't have a perfectly normal A1C, because with time, the cells that make insulin in our body sort of die off a little bit. And so it's tough to keep your A1C perfectly under control without medications, but those are some of the ideas to do it. What is the best time to check my glucose? So, if you are a new onset diabetic patient, we ask you to check before meals and 2 hours after meals. You give this data to your provider so that the provider could customize the medications for you. If you have more high blood sugars after meals, there's certain medications that your provider will use. If you have more of a tendency to have higher blood sugars fasting in the morning, your provider will customize your medications to combat that. So early on, check before meals and 2 hours after meals. That doesn't mean that you will continue to have to do that, during the course of your disease state. In fact, your provider may tell you to alter that depending what he or she wants to see. What are the signs or symptoms that my blood sugars are too high? So as I said, high increased thirst, increased urination, getting up in the middle of the night to urinate multiple times, blurred vision, unexplained weight loss, unintentional weight loss. Those are the warning signs that your blood sugars may be too high. How often should I see my doctor to optimize diabetes treatment? Early on, when we see patients that have newly recognized diabetes, we're seeing them every 3 months. And then as things start to settle down and we have good levels of medications and good levels of blood values, then we lessen that a bit. Go ahead.
I see a question here about exercise.
Yes.
What type of exercise is good to manage diabetes? And
Yes.
also, I would say similar exercise would be good for your heart as well. So I usually recommend a good amount of moderate intensity exercise. So, that's not exercise where you get on your bike and just kill yourself till you want to fall on the floor. But it's a kind of exercise that gets your heart rate up, gets you feeling a little bit short of breath, a little bit sweaty, but you could do it for 45 minutes or an hour. And you should, so I would say about 45 minutes, 3-4 times a week of that moderate intensity exercise would be good for both diabetes and heart disease. I would say I would add in that strength training too, especially with for diabetes. Dr. Tavani, I'm sure you agree with that.
Yep.
Building muscle, your muscle is one of the primary users of glucose, one of the primary ways you can clear sugar from your bloodstream. And also, of course, important for women for other reasons, to keep your, your bones healthy. So I would usually say a couple of strength training sessions per week is a very good idea as well.
Indeed. Can you comment on the new diabetes medications used to also treat heart disease? So I'll start, and Dr. Caroline, if you want to add in or jump in at any time. So we'll start with the GLP-1 receptor agonist. So These are medications like liraglutide, Victoza, semaglutide, Ozempic, and Rybelsus, and dulaglutide, which is Trulicity. So these are medications that have been shown to reduce major adverse cardiovascular events, which are defined as non-fatal heart attack, non-fatal stroke, and cardiovascular death. So in the realm of atherosclerosis, if a patient primarily has atherosclerotic disease, we migrate toward the GLP-1 receptor agonist class of medications. And then the other new class of medications that have been out on the market for several years now, the SGLT2 inhibitors, sodium glucose cotransporter inhibitors. These are medications that have been shown to reduce heart failure complications, hospitalizations for heart failure, the need to go on to dialysis, worsening kidney function, decrease in proteinuria in the kidney. So in the realm of heart failure, if a patient primarily has heart failure symptoms and signs of heart failure disease, we would tend to reach for the SGLT2 inhibitors.
I agree. Those medications have definitely been a game changer.
Yep.
And both the SGLT2 inhibitors and the GLP-1 agonists have shown very good benefits from a cardiac standpoint, in addition to their impact in helping us manage diabetes. So that's been a good addition. I see a question here. Can you review atypical symptoms of MI, which is a heart attack in diabetic women? So, there can be a wide spectrum here. The classic presentation that we all think of is substernal crushing chest pain, maybe that radiates to your arm, causes sweating and shortness of breath. Sometimes it's not so obvious, especially in women and especially in diabetic women. It can be subtle. It could be nausea. It could be just shortness of breath. It could be back pain. Could be vomiting. But you always know that something, the patient just kind of knows that something is wrong. A lot of times it could be symptoms that occur with exertion. So maybe, you yesterday you were able to climb up the stairs with no issues, and today you're taking 3 steps to the bathroom and you're having, something telling you to stop, whether it's, chest pain or nausea or shortness of breath or throwing up or arm pain, numbness or tingling. It can really vary. So, I just encourage women to just, you have to know your risk. And if you are at high risk, then you have to be more in tune to these kind of, you should have to be more in tune with your body. And, when you're in a situation where you're having symptoms that are limiting you or making you feel like something is really wrong. So, there's no cap on what the presentation could look like. It could look different. Sometimes some people present with tooth pain or facial pain or neck pain. But it's the bottom line is something is just wrong. And that is something that, the patient usually senses, but maybe when they try to describe it to somebody, they get dismissed. So you just have to make sure to be your own advocate in that situation.
Well, thank you again for answering some really excellent questions. And if any of you wants to learn more about our other Heart Month webinars, you can log into www.mainlandhealth.org/heartmonth to register. We still have several webinars coming up throughout the month. And if you have questions about your heart health, you want more information about Women's Heart Initiatives, please feel free to contact us at MLH Women's Heart at mlhs.org, or you can call us at 484-476-3WHI, 484-476-39544, and we can help you either answer some questions or really navigate you if you need help figuring out which kind of physician you need to see. However, do not call us for any medical emergencies. Remember, for medical emergencies, you have to call 911. You can also join us on Facebook, facebook.com/group/MLHWHI. And have a good evening, and thank you for joining us.